right, good morning, everyone. I'm David Liddle, one of the advanced imaging cardiologists here in Pittsburgh as well. Work as a part of this excellent team. We're just moving up to the podium. I'm going to move on to the question and answer panelist discussion part of this session. I am monitoring the chat up here, so we'll try to incorporate your questions. And we got a few during those excellent talks, so we'll jump right into things. I think going in a similar order to our presentations, maybe we'll start with Dr. Weinberg, our fetal expert. One of the questions that came in, Dr. Weinberg, was about hearts early on, imaging in that 12-week early gestation period that can look pretty similar in regards to the aortic valve and aortic stenosis, but can evolve in very different ways and different phenotypes. I think the question is a very good one and also a very hard one. How can we predict what's going to happen in the future for these kids as it influences counseling and management quite a bit?
Yeah, thank you. It's a great question, and I agree it's a really hard one because especially early gestation, typically we are seeing these women between sort of 16 and 24 weeks because that's when they something abnormal has been picked up on the OB ultrasound. But in some places, early obstetric ultrasound is able to identify some changes with the heart, and so in some cases, we are looking on the early side at the heart, and it can be very difficult to predict which babies are going to have, progressive stenosis, but also progressive left ventricular dysfunction, and who's going to, which LVs are going to become hypoplastic versus those that are going to stay at a more normal size. So this, again, there was a couple of those studies that I mentioned that looked at the more globular appearing left ventricle as opposed to the narrow ventricle. And certainly I think that if there's dysfunction by mid-gestation, early on especially, but if there's left ventricular dysfunction at by 20 weeks or even 24 weeks, that's a much worse prognosis than those that have normal function. It's much more common with isolated aortic valve disease to have late gestation dysfunction. So in some of these case series, there is a significant percentage that by 35 weeks gestation or later gestation like that will have some left ventricular dysfunction. And so the development at 35 weeks is a very different situation than the development of LV dysfunction or hypoplasia at 20 weeks gestation. So I think the earlier that those things are seen, of course, the severity of aortic stenosis by gradient, by Doppler gradients, that there is a correlation with the higher gradients earlier in gestation being related to worse growth of those left ventricular structures, but not always. Like we all have seen those cases where there's a significant gradient even at 20, 24 weeks that end up still preserving the left ventricular size and function. So it can be challenging. I think those fetuses also that show interval growth of the left heart structures from the fetal at 16 weeks or even earlier to 20 weeks to 28 and 34 weeks, whatever it is, those that show that the aortic valve annulus, the mitral valve annulus, the left ventricular dimensions are continuing to grow during that time period, whereas those that have worse growth were more likely to be single ventricle outcomes. It's a tough
It's a tough one. I think you hit on a lot of really great points, though, and I think one thing that I noticed throughout all of the talks really is just the evolution of disease is such an important predictor, and the importance of not just one fetal echo, but serial echoes, serial follow-up can make a big difference.
And one other point on that I meant to say is that because of that, these are fetuses that we follow a lot more closely than other disease. So when we identify aortic valve stenosis at mid-gestation, we are seeing these women back often every 1 to 2 weeks for another look at the left ventricular size, the progression of the valve, and so that is a very important thing that these fetuses require a little closer attention than with other kinds of congenital heart disease.
Thanks so much. One of the other questions that came in during the presentation, I think is a great one for you, Dr. Lanford, and actually a few coming in now that maybe are related. when thinking about, so I think you showed beautiful pictures of the echo imaging and showed that you can obtain different gradients. And obviously there can be aortic stenosis at many different levels, subvalvar, valvar, supravalvar. But one of the specific questions that came in was about how much gradient do you tolerate across the LVOT in patients that are asymptomatic? And we've had another similar question about a 2-year-old with moderate to severe aortic stenosis who has been similar since he was born and has also been doing very well and not had symptoms. When do you make that hard decision?
So as I showed, there's multiple different types of LV outflow tract obstruction, so I think you sort of have to break them down. To me, it's all a risk-benefit ratio. I can choose the easier ones. Subaortic membranes, if you start to, people use the criteria if you start to see aortic insufficiency. If, for me, there are some subaortic membranes that aren't progressive, the gradient doesn't change, I don't necessarily intervene on those, but if you see progressive LV outflow tract obstruction, because the risk of the surgery is much less than I would say than when we're talking about a Roscono. I will say that some of these, the example that I showed, there was clearly left ventricular hypertrophy, there was severe outflow tract obstruction. That was not going to get better. It was progressive. I think that child had a peak gradient in the 80s, systolic and means in the 50s, so I think that certainly met criteria. Also, a lot of the ones we're showing you, they're 2 or 3 years old, so it's really hard to tell about symptoms. The other one, so subaortic membranes were relatively early aggressive on. I think the other one is supravalvar aortic stenosis, because as I've shown, the aortic valve leaflets progressively get damaged, and so you can take what is just supravalvar AS and make it an aortic valve leaflet disease. And I think most of us cardiologists, regardless of the imaging, are still worried about the coronary ostia and would not feel happy about sitting on a supravalvar AS and having a sudden event. I also don't think that I've ever seen supravalvar AS improve over time. I think it is a sort of a progressive disease in the center-tubular junction. The complex ones, I will tell you there are a few patients, I can remember one in particular, that I would take the data to Dr. Morel to say, what did he think he would do? And he said Roscono, and I said goodbye. We're going to sit a little bit longer because, that is a much bigger surgery with the issues of an RV to PA conduit and the issue of heart block when you're throwing in the Roscono. And so I have a sort of a much higher threshold for that particular surgery than I would for some of the others. I hope that addresses most of the ones we talked about.
No, I think that really nicely went through it. It's sometimes easier to answer that question than others, and it's very broad, but that's, I think, where it's putting the whole picture together in some of those more complicated cases. Makes a lot of sense. A personal advanced imaging question that I'm curious about, and I think trying to blend and use this panel of experts from all levels of imaging, but one thing we've talked a lot and shown beautiful pictures of aortic valve imaging from an echo standpoint, both TEE and transthoracic. I wonder, Dr. Oliveri, if in your perspective, there's different ways to do advanced imaging, cardiac CT in particular, and those comes with different amounts of radiation to the patients. Is there ever an indication for using more radiation to get more advanced imaging of an aortic valve, or is it that bigger picture that you talked a lot about in your presentation that's really the benefit of the cross-sectional piece?
Yeah, I think it's a great question. These are the things you and I think about all the time, and hope to find good answers for our colleagues and for the patients. And I think you broke it down beautifully, David. It's like, would you expend a little more radiation, get a solid, beautiful picture of the aortic valve leaflets if a repair was being considered, or if you needed that versus sedating them, dropping a probe and doing a TE of that? It's a great question. I think TE is, I don't want to say democratized, but it's more widely available imaging technology that is pretty easy to do, easy to use, relatively easy to interpret. And it doesn't come at the expense of a lot for the patients or the families, and it's very reliable. So I think TE is always there, can always be utilized. And then I know there are some really great. There's been some really great work by specific specific centers who have developed like valve programs where they get, and I think Diane showed this in your talk, Diane, it was really beautiful, where you can really fine tune and take your CT imaging technology and really like image beyond just, you know, a size or a valve morphology. You can really understand how the leaflets go up to each other and what type and thickness of attachments there may be in the supravalvular region using CT and doing it over the cardiac cycle. So I think that if you're in a center where you can do that, oh my God, do that.
Yeah.
But if you're not, if you want to start that type of a center, I mean, there's people out there who have done this, but TE will always be there for us. It's a really nice option.
Excellent, excellent. We may be right at 11:30, or do we have time for one more question?
We can ask some more questions.
Okay, we've got time for one more question from the chat. Maybe a question for anyone on this panel, but thinking about that first echo on somebody that's done with aortic valve pathology, are there specific things that you want to see in that initial report that you're putting together commenting on the aortic valve?
They're all looking at me here. So, well, certainly, are we talking about isolated aortic valve disease, or in general? I mean, so in our report, certainly, and it's an ICAL requirement that the aortic valve annulus, the sinuses, actually, it's just the sinuses, actually, and sinus. So certainly, we do get that on all patients, and the ascending aorta. Then the aortic valve leaflet morphology, we do describe. So those would be the sort of the main things. I mean, obviously, we also look at the function of the aortic valve, so the gradients in insufficiency, and then LV size, systolic function, LV hypertrophy, and then certainly if there's any other associated lesions, which would be mitral valve, I mean, anything left-sided. So mitral valve disease, the example that I showed, I didn't point out, but that child actually has a parachute mitral valve and the arch, looking for a small arch.
I wanted to ask one thing for the echo docs. So sometimes in kids with aortic stenosis, you do see a narrowing in a sinotubular junction. It can be really tricky to know if this is really AS or supravalvular AS. And obviously, the management of the conditions is different, because if supravalvular AS, we would send them for surgery for surgical repair, while the other, we balloon in the cath lab. And even in the cath lab can be a little tricky, because even putting catheters, it's very hard to get a catheter that's just sitting between the leaflet and that ridge. Do you have anything to say on what tricks you might have in the echo lab to differentiate the two, so we can do send the patient to the right procedure?
I mean, I can start, but certainly welcome both of your thoughts. I totally agree with you, Jackie. It's a tough clinical situation, and it's like the smaller the child, the tougher it is, because everything's all crammed together and not a lot of space to discern. And I feel like things that I look at, and I don't know that this is published anywhere. This might just be like things that are in Lauren Oliver's brain, and so use at your own risk. But certainly looking at like the annulus size and the degree to which I believe that the valve leaflets are doming, i.e. not getting out of the way, like not, Libby, you showed it beautifully how the leaflets can sometimes rest back in the sinuses and then still have remaining attachments up to the STJ. Like those features I think are really important. And then looking at the STJ, I think the point I try to make in the talk, and I really do believe, like just even subtle narrowing in the STJ is important, usually is important. And so I think that having a size and Z-score of the STJ, a size and Z-score of the annulus, looking at how the leaflets like behave within the root and the degree to which they're getting out of the way versus getting forced to stay in the way is important. And honestly, I've been in this situation, I think we've all been in this situation where sometimes the problem's both, and you don't realize it until you go in and relieve one of the obstructions, do a TE, post-op TE, and then you unmask terrible AS, or you unmask supravalvular AS. I don't know if you have other comments about that too, please.
Also, just a note of caution that I feel like in a lot of these cases that are prenatally diagnosed, when a baby is 1 hour old and you're doing an echo, the left-sided structures can look and measure small. And if you wait 24 hours, we've all seen this happen, that we're very worried that something is not going to be an adequate left side. And 24 hours later, those structures have had time to transition to the postnatal world and measure more normally, more proportional to the right-sided structures. And so just a word of caution, too, that if a baby is stably supported in that period, that we have time to evaluate and make those decisions at 24, 48 hours of life, as opposed to, the day that the baby's born. I think that can be helpful. And I think even, that distinction between valvar disease and narrowing at the STJ can be more or less apparent once you've given the baby a little more time to transition.
I'm going to add a little bit more to what Dr. Oliveira had said. Actually, I'm going to involve Diane Spicer. So one of the things, at least when I see that the aortic valve leaflet has an attachment to the sinotubular junction, I think of that as more leaflet disease, but I may be wrong on that. You have any comments about that, like whether that helps distinguish?
No, I don't know echo-wise if it would
Yeah.
help distinguish that or not, because I'm not an echo expert.
But when you see attachments like that, when we see them on echo, when they're attached, there's literally attached to the tip of the leaflet's attached to the sinotubular ridge, or there's a thing. Does that correlate with sinotubular disease, junction disease, or is that more look like leaflet disease?
Well, in that case, I showed a Williams syndrome. There's typically thickening at the sinotubular junction, and as you showed in some of your echoes, the leaflets are almost coapting with the sinotubular junction and having that elliptical appearance kind of backwards from what you normally see. So I think over time, some of those things develop just increased rubbing of the fibrous tissues get increased.
Yeah.
So I think it could be a couple of different dynamics that are occurring,
And also, Dr. Kortzer, I'm not sure that you can actually tear that attachment to the sinotubular junction, so that may be another indicator that it's not a great cath candidate.
Excellent. Well, this was a great discussion. Thank you guys so much. We're going to take a little turn. I'd like to talk about imaging all day, but we have some other topics too. So